السلام عليكم.
وعليكم السلام، زي حضرتك يا دكتور؟ ايه الاخبار؟
تمام، الله يعطيك العافية. رحاب.
ايوه انا رحاب. ايه الاخبار؟ كله تمام.
تمام، الله يعطيك العافية. 10 دقايق كده ونبدأ إن شاء الله.
ايوه تمام باذن الله. انا بعت لحضرتك البايو بتاع دكتور ماجد والدكتور التاني اللي هيكون معانا.
وصلتني، الله يعطيك العافية. ومدته حيكون ساعتين صح؟
ايوه مظبوط، من الساعه 9 من الساعه 8 للساعه 10، اللي هو من 9 ل 11 هنا.
تمام، يعطيك العافية.
السلام عليكم.
وعليكم السلام.
وعليكم السلام، زي حضرتك يا دكتور؟
أهلا رحب، هلا بروفيسور ملاك.
وسهلا، أهلين دكتور، حياك الله. الحمد لله، كيف الصحة؟ إن شاء الله بخير.
خير، الله يسلمك. رحاب، ياسر موجود ولا مسافر؟
لا موجود معانا، هو متابع بس انا المسؤوله النهارده.
طيب، شكلنا داخلين على الالايف والذا اتنديز.
احنا ظبطناها خلاص.
بس انا قاعد اشوف الاتنديز معانا شكله.
هلا يا دكتور ماجد، إيه يا باشا انا معاكم.
احنا
الو.
الايف.
لا لا لا، لسه ما بدأناش، بس ده باينين، بس لا احنا لسه ما فتحناش الويبينار.
لسه ما فتحناش، ها.
لا لا، دولك اللي في الويتنج ليست، بس في الويتنج روم.
مم.
الأتنديز ما شاء الله 1800 ما شاء
اه،
الله.
العدد اللي مسجل المرة دي كتير، بس احنا عندنا الكباسيتي 1000، بس احنا عاملين حاجة اللي فوق ال 1000 هيعمل لهم هياخدهم على مكان تاني على نفس بتاع، يقدروا برضه يسجلوا ويدخلوا ان شاء الله.
تمام.
هكلم بس الهنوف عشان اشوف السبيكر بتاعهم لانه لسه ما دخلش.
احنا الان 1933.
مظبوط.
ياسر، ابغى اسوي شيرنج السكرين بس تجربة على اساس اتاكد ان البرزنتيشن شغال.
اه اتفضل يا باشا.
تشوفون السكرين واضحة؟
واضحة، أيوة واضحة.
طيب انتم ارسلتوا للاذر سبيكر اليوم ولا ما ارسلتوا له؟
اه بعتنا له، انا كنت لسه كلمت الهنوف دلوقتي، هتكلمه عشان يدخل الاوتوماتيك. هو بس بقى الانترناشونال سبيكر.
ايش؟
هو بقى الانترناشونال سبيكر بس، هو احنا اتنين سبيكر، حضرتك والانترناشونال سبيكر اللي معاهم التركي.
اي بس ما دخل، متى بيدخل؟ ما بقى له 3 دقائق.
انا لسه قافل مع الهنوف دلوقتي حالا، لان هي اللي متابعه معايا.
طيب.
كلمتها من شويه.
دكتور ماجد، أعتقد لو ما دخلت تبدأ محاضرتك، صح؟
دكتورة ملاك، انت اللي بتسوي التقديم صح؟
إيه، حقدمكم. فأم just saying لو تأخروا كده عادي نبدأ بمحاضرتك، صح؟
صحيح، بس الأسئلة تكون بعد المحاضرتين على
إيه،
أساس ما يكون في تأخير.
أوكي إن شاء
يعني
الله.
لو جاء دخل هو الآن، هو يبدأ، بعدين تقدميني، بعدين أنا أبدأ،
تمام.
بعدين في النهاية الأسئلة للاثنين.
تمام إن شاء الله.
الله يعطيك العافية.
الله يعافيك.
دكتورة ملاك،
أيوة أهلا دكتور، تفضل.
أحتاج منك على أساس المقمة السنة دي حيكون في جدة إن شاء الله. أحتاج منك التايتل of your lecture if you want to present.
متى حيكون إن شاء الله؟
هيكون 30 31 أكتوبر و1 نوفمبر.
إن شاء الله على خير بإذن الله. حرسل لك فيه إن شاء الله محاضرات، إن شاء الله تكون نايس. حرسل لك التايتل.
ممكن ترسلينها لي على بكرة كذا؟
بإذن الله، يس ريدي إن شاء الله.
إن شاء الله.
دكتور ماجد.
ايوه.
انا اتكلمت مع لينوف، هي كلمته وقالت ممكن حضرتك تبدا، وبعدين هو اول ما هيخش، اول ما يجون هيبدا هو بعد حضرتك المحاضره ان شاء الله.
هو رد عليها ولا لسه؟
هو رد عليها وقالت لي بعد كده، كلمتني قالت لي دخل، قلت لها لسه ما دخلش. كلمتها تاني فقالت لي لو كده، قلت لها لو كده ممكن الدكتور ماجد يبدا وبعد كده هو يدخل. قالت لي ممكن الدكتور ماجد يبدا وهو يدخل، شكله لسه قدامه شويه.
مم. طيب ننتظره 3 دقائق زيادة. هو دخل الحين.
دخل خلاص. طيب نخلي رحاب، ممكن نجرب على السريع mع الدكتور بعد كده نبتدي.
Hocam merhaba, nasılsınız? Her şey yolunda mı?
Oh, kimle konuşuyorum? Türkçe.
Ben Rihab. Lika şirketten çalışıyorum. Bir de konuşuyorum.
Aa,
Nasılsınız?
çok iyi. Süper. Çok şaşırdım.
Hiç sorun değil. Tamam, şimdi dinleyebilir miyiz? Her şey hazır olarak.
Tabii her şeyim benim hazır.
Tamam. Siz onu aç, dinleyeceğiz. Çalışıyor
Okay.
mu, çalışmıyor mu?
All right. By the way, let me hello to Dr. Majid. How are you?
Hello, Professor Paris. How are you?
I'm fine. How are you doing? So, by the way, Majida is calling me. Probably she thinks I'm not connected. Let me answer real quick.
Mhm.
Hello, Majida. Hello. Good. How are you doing? Yes, I can hear you. Yeah, I'm connected, by the way. All right, probably you want to just check that, right? Yeah, that's fine. Yeah, I'm connected. I'm talking to Dr. Majid, yeah, right now. All right. Okay. All right. See you. Bye. Sorry for that.
No
Just let
worries.
me share my slides, maybe.
Mhm.
So that's obviously the last slide. Let me go back. Can you see them?
Yes.
Evet hocam.
Super. Thank you. Or I can make it full screen if you like this.
Yeah, now
Tamam.
it's better.
Süper.
Okay, so I will stop sharing now.
Okay, then Professor Malak could present you. Yasser, we can start now.
Yeah, I'm totally fine whenever you want.
Okay, we will start now, okay?
Okay.
Ready? Can we start?
Yes,
We
sure.
started.
So good evening, everyone. On behalf of the organizing team, I'm delighted to welcome you all to today's webinar, Living Without Adipose Tissue. We are honored to bring leader experts, researchers to share knowledge, experience, and latest advances in understanding and managing lipodystrophy. We'll start the first presentation with Professor Paris Akenji, who is a professor of internal medicine specialized in endocrinology and metabolism with a distinguished focus on lipodystrophy syndromes and rare metabolic disorders. Professor Akenji is a leader, is based on Izmir, actually, Turkey, and brings over 25 years of clinical research and academic experience. He earned his medical degree from Ege University and completed his training at Dokos Ilol University, with further academic appointment and leading institutes at different leading institutes, including University of Michigan and University of Leeds. Professor Akenji has authored more than 130 peer-reviewed publications, and he is the founder of Turkish Lipodystrophy Study Group. He is also an active member of European Consortium of Lipodystrophy, contributing significantly to global understanding and treatment of rare adipose tissue disorders. So we're honored to have him with us today to start with the important discussion, this webinar, Living Without Adipose Tissue. Go ahead, please, Dr. Akenji.
Thank you, Professor Alhamdi, for the nice introduction. And then also thank you for the invitation. This is great that I can share some of our experiences with you today. So let me first share my slides again. There we go. I think you can see them, and I can maybe make them full screen. That's better. Okay, so today we will mostly be focusing on the more severe forms of lipodystrophy. That is generalized lipodystrophy, and mostly our focus will be on congenital generalized lipodystrophy. However, because this is an heterogeneous and complex disease state, sometimes it is not very easy to distinguish all of these forms from each other. That's why in some slides you will see I will be actually touching some of the other versions of lipodystrophy just for the completeness of the presentation. First, I have to show you my disclosures here in this slide. And then the next slide is from the company showing some disclaimers. All right, and then we can start our presentation with this. This slide, I actually tried to simplify things by creating this slide, but I don't know how successful I am because I prepared the slide for a very recent meeting in Zagreb, and I thought I could actually make lipodystrophy a bit easier for people. But then when I started putting things together, and I noticed that I'm actually making maybe things a bit more complicated. But still, I wanted to keep this because I think this slides show us two important things. The first thing is about the definition of lipodystrophy. If you look at the top of this slide, you can see lipodystrophy is more about fat loss, adipose tissue loss, because sometimes this can cause confusion. Some young physicians sometimes say, all right, if there is a disease affecting adipose tissue, any kind of, changes, etc., in adipose tissue, that may also somehow include things like obesity. Can we call them lipodystrophy? The answer is no. When we say lipodystrophy, we always talk about fat loss. So there should be documented fat loss, and then we have to make that certain that the patient is losing fat or was born that way. So that's a very, very important distinction. So, and if you look at the slide, there are two major types of lipodystrophy. One is generalized and the other one is partial. When we say generalized, it is affecting the whole body. So all adipose tissue compartments are more or less affected. So we can call it as near total fat loss, because sometimes in very small regions you can still see some residual fat, but overall fat loss is actually affecting the whole body. For partial lipodystrophy, we are talking about some parts of the body affected by fat loss, but it is not affecting the whole body. So still in a significant portion of the body shows normal or even sometimes accumulated fat tissue. That's the most important distinction here. And then we have different disorders. These disorders, they have additional things, but they also have lipodystrophy. One example can be progeroid lipodystrophies. These patients are typically progeroid. They have signs of early aging, but they also exhibit lipodystrophy. In some forms, they can exhibit generalized, but in some forms, they can exhibit partial lipodystrophy. But still, you can document fat loss in these patients. Another example is some complex syndromes, or for things like bone marrow associated lipodystrophy. In these patients as well, you can document fat loss. And a very interesting another disorder here is lipomatosis, because as you know, in lipomatosis, there's actually adipose tissue overgrowth. But not in all forms, but in some forms of lipomatosis, you can also see fat loss from certain parts of the body, and mostly lower limbs are affected in this rare condition. So these patients can be also classified under the general umbrella of lipodystrophy. HIV-associated lipodystrophy is actually a very important term here, but technically HIV-associated lipodystrophy and today's talk, they are differently classified. So we always classify rare lipodystrophy syndromes under the umbrella of non-HIV lipodystrophies. This is mainly because of the clinical studies was developed that way at the time. But also it's important to make that distinction because HIV associated lipodystrophy has a definitely different pathophysiology, and also these patients may suffer from additional issues that we usually don't see in patients with rare forms of lipodystrophy. So, but technically, if you look at these patients, they also have partial lipodystrophy, an acquired form of partial lipodystrophy. But as I said, we always keep these things separate. One additional thing that I have to remind you here is localized lipodystrophy and some regional fat loss conditions like Perry-Romberg syndrome. These patients, they typically have fat loss. That's why under our standard definitions, we have to classify them as lipodystrophy. But the problem here, these patients, they usually don't exhibit metabolic abnormalities. That's why we always try to keep these conditions separate. But just to remind you, sometimes, especially in some patients with acquired generalized lipodystrophy, fat loss, when it first started, can be localized or partial, but this can progress over time into a generalized lipodystrophy fat form. That's why it would be important for some of these patients to monitor progression of fat loss. But if the fat loss is just affecting a small part of the body, like fat atrophy that we see sometimes after insulin injections, these are localized lipodystrophy cases, and they are not part of the typical rare lipodystrophy syndromes. So I will just show you some pictures of these different phenotypic expressions, and maybe I can use a pointer. Let me see. That's great. Yes. So this is a typical congenital generalized lipodystrophy case, as you can see here. So this gentleman looks very athletic and healthy, but if you look closely to this person, so you can actually not see any subcutaneous fat at all. Probably the most important alarming thing for this kind of patient is the presence of metabolic disease in a person who seems very athletic and healthy. That could be the most important thing that make us think about lipodystrophy syndromes. And if you look at this family from Brazil, very nice family, even in the same family, sometimes fat distribution or fat loss pattern can be a little bit different. So if you look at these daughters, and here is the mother, for example, the daughters have more a partial form of lipodystrophy with very well preserved fat around the face and neck. But if you look at the mother actually has a form of generalized lipodystrophy. Mostly there is also no fat tissue around the face and neck. This is caused because the mother has a homozygous variant of a laminae variant, and then the daughters are heterozygous for the disease. That's why in their case, so the fat distribution can be, and also disease severity can be a bit different. So this girl over here has acquired generalized lipodystrophy, and if you look at this case and compare it to this gentleman, the fat loss pattern is actually very similar. So you can see a distended abdomen over here that's due to a large liver she has. The only thing that can help you to distinguish these two cases is the onset of fat loss. So this girl was born with normal fat tissue and then started losing fat at some point of life. And here is the typical lipomatosis case and the progression of the disease. So if you look at this case, you can easily say there is a lot of adipose tissue overgrowth in the upper part of the body. But if you look at her limbs are clearly lipoatrophic. So that's why here we can talk about the presence of partial lipodystrophy in a case of a lipomatosis. This is an MFN2 patient. And here is another patient, again with adipose tissue overgrowth in the upper part, but clearly lipoatrophic lower limbs. So these were some examples. And here, if we look at the classification again, so as you can see here, we typically classify patients as generalized or partial lipodystrophy. And for each form, then we use another classification based on their etiology that can be genetic or acquired. So, and then if you look at the congenital generalized and acquired generalized lipodystrophy fat loss patterns, you can see these fat loss patterns are very, very similar. As I said, the only thing that can help you can be the fat onset, fat loss onset of fat loss. And the other thing that can help you is the consanguinity in the family, because in congenital generalized lipodystrophy, most forms of the disease are autosomal recessive. That's why it's very common that you will find consanguinity in the family, and these kind of things are more common in our parts in Middle East compared to the rest of the world. So in partial lipodystrophy, fat distribution is totally different. That's why it's a very helpful clinical presentation that can help us to make the right diagnosis. In familial forms, fat loss always affects the lower part of the body. These patients, they have lipoatrophic limbs, muscular limbs, especially lower limbs. But if you look at their upper part of the body, around face and neck, there is always some fat. And in some cases, there is also fat accumulation. This would be very helpful. In acquired partial lipodystrophy, though, fat loss is acquired, starts at some point in life, and always starts from the upper part of the body, from the face, and usually spreads downwards, and the lower part of the body is protected. So it's a typical fat distribution pattern that can help you to make the diagnosis. One thing that I have to remind you here, although familial partial lipodystrophy is a genetic disorder, these patients are born with normal fat, and they start losing fat in childhood, usually a bit later in their childhood times, and fat loss becomes prominent, obvious around puberty. And after puberty, it is easier to diagnose these patients. That's why please don't get confused. If you see a patient with familial partial lipodystrophy, they can still show you some baby pictures or early childhood pictures with totally normal person, right? Showing a totally normal fat distribution. That is okay with this form of the disease. But if you are careful enough, after age of 5, 6, so you can a bit start seeing fat loss from the lower body, especially limbs. And then when you approach puberty, especially females, you can then easily notice fat loss. So these patients are, these phenotypes are for some reason more obvious in females. So there are different, hypotheses there. And one thing is probably the fat loss is more important for females from physiological perspectives. So always the phenotype is easier to recognize in females, because a muscular person, a muscular man, can be easily perceived as a normal person in this population. That's why females are always easier to diagnose. But you have to do a physical examination. You have to undress the patient. Otherwise, it's almost impossible to detect that. That's why a full physical examination is very important to diagnose these patients. So I'll show you more pictures with patients with congenital generalized lipodystrophy, and there are differences between these subtypes, and some of these subtypes are actually common in Middle Eastern countries. So here you can see a typical CGL1 case. CGL1 and CGL2, these are the most common and most typical versions of congenital generalized lipodystrophy, as you all know. But still, there are some small things that can help you to make the diagnosis. Nowadays, genetic testing is accessible. That's why all of us are ordering genetic tests, and maybe we don't need this anymore. But there are some differences. For example, one interesting observation is the preservation of retroorbital fat, as you can see here, in patients with congenital generalized type 1. But if you look at the type 2 patients, you don't see any retroorbital fat that is preserved. That's a very interesting observation. The same can be also observed in the scalp. Look at the scalp of CGL1 patient. You can very easily see a white signal that is fat tissue. But if you look at the CGL2 patient, you cannot see that signal. That's very helpful. And also, if you measure adiponectin, not leptin, adiponectin, you may see a little bit of adiponectin in patients with CGL2, but usually ACPAT2 patients, these are CGL1 patients, they usually don't have any adiponectin. In CGL3 and CGL4, these are rare patients, but there are additional clinical characteristics that can help you to distinguish them from others. For example, cardiac arrhythmia is a cardinal feature of CGL4. CGL4 is specifically common in Oman, so there is a founder effect there. And in these patients, they may die because of the cardiac disease at early ages. For this reason, in patients with CGL4, cardiac assessment is very important to complete as soon as the diagnosis is made. In CGL3, so that's the first described case, and the second case is actually in Turkey. So in these patients, you can see gastrointestinal abnormalities, achalasia, that sort of things, and gastrointestinal this motility can be also observed in CGL form. These patients, technically, pathophysiologically, they are a bit closer to each other. As you know, one disease is caused by a CAV1 mutation, and the other one is caused by CAV1 mutation. So these are important proteins for the caveola formation in the cell. And then in this girl over here, this girl, as you can see, this girl is typically progeroid. This is a typical lamin A mutation causing generalized lipodystrophy and also at the same time causing progeroid features. But if you look at this case metabolically, this case is actually not any different than from other CGL cases. This case also develops very severe tip hypertriglyceridemia, diabetes, etc. So in that means, so this patient has all metabolic features of generalized lipodystrophy, but a different genetic mutation. There is no consanguinity. This is a heterozygous mutation, and usually this is a de novo mutation. So you won't see anybody else in the family with the disease. So these are some examples. And if you go back to acquired generalized lipodystrophy, in some of these patients, they may describe you an episode of panniculitis, fat loss starting as small areas in their body and then progressing and generalizing to the other parts. In some cases, you may see additional autoimmunity, like this girl over here. Here, she has dermatomyositis. And in other cases, you may see additional autoimmunity, like this girl over here with very severe autoimmune hepatitis. So additional autoimmunity can be detected in patients with generalized lipodystrophy. But in the end, they also have generalized fat loss, and they will also suffer from metabolic problems caused by generalized fat loss. So what are these metabolic problems? So there are two things over here. These patients, they lose fat. And because of the fat loss, because adipose tissue is the only major source of leptin, their leptin level go down. And also, because they lose fat, they lose adipose tissue, now they have very, very limited storage capacity for extra energy. They cannot store extra energy in their adipose tissue anymore because they don't have it. And then also they have very severe leptin deficiency in patients with generalized lipodystrophy. And as a result of these patients will be always in a caloric surplus, energy surplus, and also they will start accumulating fat in ectopic tissues like the liver. And these are things they are very rough story triggering metabolic abnormalities in these patients. So, and in the end, this leads to a multi-system metabolic disease plus additional things based on their molecular etiology or acquired etiology. And as you can see in this slide, these patients may suffer from multiple problems. If you ask me what are the typical problems, maybe I can show you our Turkish cohort with congenital generalized lipodystrophy and how they develop these abnormalities over time. As you can see here, these patients, they develop high triglycerides in childhood. So, and then the high triglycerides that develop in these patients, they usually progresses. And then at some point, they become really severe and then may cause episodes of pancreatitis. If you look at here, hepatic steatosis in these patients starts usually very early. If you do an ultrasound or MRI as a child, you can detect hepatic steatosis very easily in these patients. This could be one of the earliest signs of the disease. Along with hypertriglyceridemia, you will also probably notice low HDL cholesterol in these patients as additional lipid abnormality. And in our experience, HDL cholesterol, low HDL cholesterol usually develops very early in these cases. So diabetes develops a bit later, but still around childhood and mostly after puberty. And these patients then progress to usually poorly controlled diabetes, despite treatments with, typical anti-diabetic agents like insulin, metformin, etc. And then these patients develop organ complications. Chronic kidney disease is a typical complication. They usually develop proteinuria, sometimes massive proteinuria. Cardiac disease, not only in CGL4, but also others, they develop cardiac disease because they are at very high cardiac risk due to their metabolic disease and also sometimes based on their molecular etiology. All of these disorders, they cause typical problems, and these typical problems lead reduced survival in these patients. So the diagnosis of lipodystrophy is challenging. So give me a second. Sorry. Yeah. So I'm connected from United States, and that's my son's home. That's why these are his roommates. So coming probably getting some stuff. Sorry for that. Anyway, so I go back to the diagnosis of lipodystrophy. And I said that's challenging. So because the disease is complex and it's a heterogeneous disease, rare disease. And then as I showed you in the pictures, there are different clinical presentations. These are, it's a very broad spectrum. And then the thing is, there is unfortunately no single test that can diagnose lipodystrophy. So, and also there are other cases like lipodystrophy, like phenotypes. And then in some patients, you can see fat loss that develops during very young ages, but these patients, sometimes they don't develop metabolic abnormalities until they are adults. So that's why we have to keep in mind, in young patients, metabolic disease can be mild. And as I said, MACE are always more difficult to diagnose. So there are multiple disorders that are important when you see a patient with generalized lipodystrophy. They are important to consider. And then as you can see here, for example, among those, malnutrition, anorexia nervosa, and here poorly controlled type 1 diabetes. These are very typical cases that we see every day in our clinical practice, and we have to be really very careful while making a differential diagnosis between disorders and these common disorders. So as I said, medical history, physical examination, and metabolic testing is very important. And also keep in mind, in acquired cases, you can see some autoimmunity. That's also important. Genetic testing nowadays is accessible, and mostly in patients with congenital generalized lipodystrophy, and 90% of them almost, you will be able to find a genetic mutation that can explain the situation for you. But in partial lipodystrophy, I have to remind you, almost 50% or 40% of these patients, they don't have a single gene mutation that can be detected. Some of these patients, they are polygenic, and in some of these cases, you cannot detect the genetic mutation based on the typical genetic panels that they are using for the diagnosis of lipodystrophy. That's why I have to just remind you, if you have a negative genetic result after a genetic panel, or even whole exome sequencing in a patient with partial lipodystrophy, so still your clinical diagnosis can be true. Still, based on your clinical findings, you can diagnose your patient with lipodystrophy. That's an important thing to say. So leptin levels are low, as I said, especially in generalized lipodystrophy, but unfortunately, only leptin level cannot diagnose the disease exactly and then accurately, because some of these patients with partial lipodystrophy, especially, they may have normal leptin levels. And then if you look at the generalized lipodystrophy patients, so they have low leptin, but especially children, they may also have normal children, they may also have low leptin, especially if they're skinny. So that's why only based on leptin level, it's almost impossible to make the diagnosis. But they are supportive. Many centers are measuring leptin. They are supportive for your diagnosis, but they're not diagnostic. Imaging is one thing that can help you a lot. So on the left hand of the slide, you can see DEXA images created and showing the fat tissue. And on the right side, you can see MRI. So MRI is very, very helpful in my opinion, but it can be a little bit more expensive and also time consuming to run. MRI gives you high resolution images. DEXA is also very helpful, but it is a low resolution image. So based on your center's clinical practice, you may choose one of these imaging methods. And then if you look at our MRI results, and we will present more results at this year's endo meeting, so MRI can easily diagnose these patients. In many of them, still there are atypical cases, and still in males difficult to diagnose, but especially pelvic MRI that can assess the gluteal fat mostly, it can be very helpful to diagnose these patients in many of the cases. So what are the helpful resources for all of us to look at if we have a patient with suspicion of lipodystrophy? So there is a guideline that will be super helpful. There is the European Lipodystrophy Group, and the group has this Ask the ECLIP Expert tool. So if you can just click on this, the European group will connect you with some sort of expert in your area, and then you can discuss your case with this physician. And also, this is the Rapid Action Plan paper published last year. It's very helpful. This paper has checklists like this that will really help. And also, there are some online applications from Spain. There is this app called LipoDDX. From Brazil, there is this machine learning algorithm called Deep Lipo. And also, this is something that we recently developed with NIH and University of Michigan and other collaborators. This is actually measuring disease severity, but still can serve as a checklist to diagnose these patients with lipodystrophy. So these are helpful tools. So how can we treat these patients? So first of all, I will show you some basics from the guideline. Diet is important, exercise is important. There are standard treatments that can be used, but for patients who are leptin deficient, it can be a bit challenging to keep an on diet and also exercise. In some patients, there may be contraindications. You can try the other medications, but in the presence of severe leptin deficiency, many of these patients may fail on standard medications. That is usually the reality in the clinical practice. So, and then if I look at the specific lipodystrophy treatment, so then I have to go back to these very elegant animal studies, my studies from many years ago. So here you can see this very nice article called Life Without White Fat. And then if you look at this model, regardless of the strategy, so whatever strategy you can use, doesn't matter. These animals, they develop severe insulin resistance, they develop hypertriglyceridemia, and they develop ectopic fat deposition, mostly in the liver. So then if you give fat back to these animals, then you can actually rescue the phenotype. So you can rescue the phenotype, hepatic steatosis improves, hypertriglyceridemia improves. You can totally correct metabolic phenotype in these animals. And the other thing is, if we don't give fat, but if you just give leptin, that's the cardinal hormone secreted from the adipose tissue, very similar to fat transplantation, you can improve metabolic phenotype, you can rescue a liver disease in these animals. And I think the next slide is the most important one here. If you give back fat, but this fat is leptin deficient, then this is not going to rescue anything. So if you give fat, all components, but no leptin, you cannot improve metabolic status. You cannot rescue metabolic phenotype. That is these important papers, 3 or 4 papers are highlighting the cardinal role, the critical role of leptin in improving these metabolic outcomes. So then leptin today, as we know from the guideline, and also I will show you the regulatory approval. So that's part of lipodystrophy treatment, especially in generalized lipodystrophy. Here, as you can see here in our 2016 guideline, it says in generalized lipodystrophy, metformin with diet is the first time treatment for metabolic endocrine abnormalities and may be considered for prevention of these abnormalities in children. And here is the regulatory approvals. In the United States, it's only approved for generalized lipodystrophy. Partial lipodystrophy study is still going on. There is a placebo-controlled study going on. But in the European Union, both generalized lipodystrophy and partial lipodystrophy patients can be treated with metformin under some circumstances, especially for partial. They have to fail on standard treatments. But for generalized lipodystrophy, there is no such requirement. So these are the regulatory status. Very shortly, I will show you clinical study results. If you treat generalized lipodystrophy patients with leptin, you improve A1C, you improve triglycerides very significantly. And then many of these patients, they are able to stop their concomitant medications, including insulin, oral antidiabetics, or lipid medications. And also, based on the role of leptin replacement in these patients, you can control satiety, you can control food intake in these patients, and also, as shown in animal studies, very similar to them, here are the biopsy results on patients treated with leptin. You can see that leptin treatment can improve hepatic histopathology in these patients significantly. As I said, these patients, some of them, they may have very high levels of proteinuria, and after leptin treatment, you can also see improvements in proteinuria in these patients. And also what happens to lipoprotein profile that is atherogenic, that also improves after metformin treatment. As you can see here, these atherogenic particles, their levels, they will improve after treatment. And also cardiac hypertrophy, mostly caused by severe insulin resistance in these patients, diastolic dysfunction, that is also other things that can improve after treatment with metformin. Also, I have to remind you, leptin is a very important regulator of reproductive health, especially in women. Many of leptin deficient patients have menstrual irregularities, and sometimes they have problems with puberty induction. So, usually they reach puberty, but there can be additional problems, and then usually menses are not regular. And after treatment with leptin, you will see very significant improvement in their hormone profile, LH, FSH, pulsatility, etc. And these patients usually become normal in means of reproductive function, and this can also improve their fertility. So this is also something that we have to keep in mind, because some of these patients, they may think they're infertile, but after leptin therapy, most of them will become fertile. That's also something that we have to keep in mind. Here's another study from NIH showing these improvements in different disease states in partial and generalized lipodystrophy patients here. And similar to what I just showed you from other studies, there are improvements in all of these parameters. And the most important thing is the survival. So here is the matched cohort analysis. Both GL and PL patients are here. As you can see here, after treatment with leptin, when these cohorts are matched, you can see significant improvement in survival rates after treatment. So there are some warnings. Maybe we can cover some of these during our Q&A session, but hypoglycemia is one thing that I need to highlight here. When you start treating your patient with leptin, insulin sensitivity will improve very dramatically. That's why you have to be really very proactive on reducing insulin doses. Normally, many physicians, they reduce insulin doses 50% directly right after therapy, and sometimes you may need further reductions, and sometimes even you may need to stop insulin. If you stop leptin abruptly, that may cause pancreatitis because triglycerides levels may increase again. This was shown in one of the earliest clinical studies. That's why you try to keep your patient on leptin, or if you need to stop, then you have to follow some sort of tapering algorithm based on the product information, or SMPC based on their location. And also, as I said, unplanned pregnancy is something important. Immunogenicity and lymphoma, these are black box warnings for lateral leptin. Lymphoma happens usually in acquired generalized lipodystrophy. It's T-cell lymphoma. There are patients who develop lymphoma in the absence of leptin and also in the presence of leptin. There is a very recently published, or actually accepted article. It's not on PubMed yet, but it is actually published in the journal. It will be available in a few weeks. So there's a systematic literature review and pharmacovigilance assessment showing that many patients, even though they are not on leptin with acquired generalized lipodystrophy, or additional patients, not many patients, additional patients can develop lymphoma. It looks like there is a link between acquired generalized lipodystrophy and T-cell lymphoma development. Immunogenicity is something that should be keep in mind, especially in patients who stop responding to treatment, because this is a biological product. Patients can develop antibodies against it, and then these antibodies can be theoretically neutralizing in some cases. That's why this is something that should be keeping in mind. If that happens, the company can provide testing for this phenomenon. Again, here are the summary of the leptin effects. We covered all of these. Just one thing I want to add, this is actually now a published article, but here in this version, I have a slide from the poster that's from the NIH. What is the best timing of treating these patients, especially those with generalized lipodystrophy? This study is aiming to address this question. And if you look at this slide, and also the full text is available, as I said, if you treat these patients earlier, in the long term, you can protect their metabolic health better. And this can also be translated in some means to organ dysfunction. For example, liver disease, liver fibrosis develop less frequently in these patients based on this analysis. So that's why this is a very important study highlighting the importance of early treatment in patients with generalized lipodystrophy. So here are my conclusions. So it's a clinical challenge, I have to agree, but still, if we do clinical assessments carefully, if we support our clinical assessment with metabolic testing, imaging, genetic testing, and additional testing as necessary, we can still accurately diagnose the disease. These patients are at high risk for comorbidity and mortality, and then these patients require a multidisciplinary approach. And with today's care, we should be focusing mostly preventing and improving their metabolic disease state and organ complications. As of today, there is no cure for lipodystrophy. However, with the medications that is available to us, we can improve metabolic disease very significantly. So that's my presentation, and I would like to thank you for your attention, and then stop sharing now. And it's back to Professor Al-Namdi.
Thank you so much. Thank you so much, Professor Akanji. Very great, a very comprehensive and informative lecture. We'll leave the question at the end of the session, at the end of the webinar, and we'll proceed to the second presentation by Professor Majid Al-Fadl, a globally recognized leader in medical genetics and precision medicine. Professor Al-Fadl currently serves as Deputy Executive Director of King Abdullah International Medical Research Center, Chairman of Department of Genetics and Precision Medicine, the Director of Medical Genetics Lab, Genomics Lab. Also, he's a professor of pediatrics and genetics at King Saud bin Abdulaziz University for Health Science, with an outstanding research portfolio. Prof. Al-Fadl contribute to discovery of more than 70 novel genes and identify syndrome that bears his name, Al-Fadl syndrome, recognized by OMIM. He's also a founder and an editor-in-chief of Journal of Biochemical and Clinical Genetics, serves on editorial board and multiple international journals, and authored about 215 peer-reviewed publications, 3 books, and a book chapter. He was a mentor for several fellows, resident, and medical student. So today with Dr. Majid Al-Fadl, we'll share an insight and understanding of lipodystrophy in MENA region, natural history, and real-world case experiences. We are delighted to have him in this webinar. Please, Dr. Majid, Professor Majid. We cannot hear you. Have you started? Are you?
Sorry for this technical error.
Yes, now it's clear. Thank you.
Can you see my presentation now?
Yes, you're in the first slide. Yes.
Hmm?
Yes, Prof. Majid, it's clear.
I cannot see it myself. I don't know why.
طب حضرتك ممكن تقفلها وتفتحها تاني يا دكتور مجدي؟ ده انا كمان مش معموله سلايد شو.
Huh? Now you can see it?
Yes.
Okay.
Yes.
Good.
Yes.
Okay. Sorry for this technical error. Thank you, Professor Malak and Professor Akelsi, for this outstanding presentation. And it's difficult to add more knowledge about the previous, more than the previous lecture. So I have disclosure that this, I will get honorarium from Amrit Pharma and Cheesy Pharma for this presentation, and also disclaimer. So we'll start with the introduction about congenital generalized lipodystrophy, which was first described by Waldemar Berardinelli in 1954, which is a Brazilian physician, and later outlined by Martin Sieb in 1959, who is a Norwegian physician. And according to that, it was called Berardinelli-Sieb syndrome. Until then, it was named as congenital generalized lipodystrophy and expanded to 5 types. So congenital generalized lipodystrophy, it's a triad of lipodystrophy, hypertriglyceridemia, and acromegaloid features. It's associated with insulin resistance that result in diabetes mellitus in around 30% of the cases, and hepatomegaly secondary to hepatic steatosis and skeletal muscle hypertrophy, and also some form, as we see in the previous lecture, it's associated with hypertrophic cardiomyopathy in 20 to 25% of the cases. It is autosomal recessive disorder, so it is caused by homozygous or compound heterozygous pathogenic mutation in one of the following gene. AGBAT2 responsible about congenital generalized lipodystrophy type 1, and then BSCL2 type 2, CAV1 type 3, CAVN1 type 4, and finally PCYT1A type 5. The prevalence worldwide, 1 in 10 to 12 million, approximately 500 cases have been reported. It's more common in Peru, Brazil, and Portugal, but no clear data about the prevalence in MENA region. However, it seems more common in Oman, Lebanon, Egypt, and Saudi Arabia. The natural history started from birth, and in infancy and childhood, you can see there is acceleration of growth and virilization. Some infants experience rapid growth, and in females, sign of virilization or precocious puberty. Hyperphagia and insulin resistant due to leptin deficiency. Affected individual have excessive hunger leading to hyperinsulinemia and severe insulin resistance. Early onset of metabolic issues like diabetes mellitus in 45% of the cases before puberty, with some requiring high dose of insulin, more than 100 units per day for management. Hypertriglyceridemia or elevated triglyceride are common, especially causing eruptive xanthoma and recurrent pancreatitis after puberty. Hepatomegaly and hepatic steatosis in early childhood, with some patients progressive to cirrhosis, particularly with the mutation in BSCL2 gene or congenital generalized lipodystrophy type 2. Well, with the age, there is worsening of metabolic complication and metabolic issue at adolescent and adulthood, and cardiac and muscular involvement occur, including hypertrophic cardiomyopathy and with muscular dystrophy-like features, including high CK level, especially in the mutation of CAVN1 gene or congenital generalized lipodystrophy type 4. Approximately 80% of individuals with homozygous or compound heterozygous mutation in the BSCL2 have mild to moderate intellectual disability, whereas only 10% of individuals with AGBAT2 or congenital generalized lipodystrophy type 2 have intellectual impairment. We have this study recently, not recently, last year we published it. It's about congenital generalized lipodystrophy from Middle East and North Africa. It was a retrospective study for 43 patients from 8 countries, most commonly from Saudi Arabia, 20 patients or 47%, Oman 13 patients or 30%, Libya 3 patients or 7%, United Arab Emirates, Egypt and Iraq and Bahrain, Palestine and Tunisia, each 1 or 2 patients. So these 43 patients, 86% of them were female, and the mean age at diagnosis 5.1 years, which is indicate the delay in diagnosis of these cases, although they are started since birth. And then parental consanguinity were found in 93% of the cases, which is unsurprising because this is the nature of this geographic area over the world. And the family history present is 67%. We found the most common were BSCL2 or congenital generalized lipodystrophy type 2, around 43% of the cases, followed by AGBAT2 or congenital generalized lipodystrophy type 1 in 34% of the cases, and then 23% of the cases has CAVN1, and as Professor mentioned that most of these cases are from Oman. The key finding from this study, we find high parental consanguinity reaching 90%, and also, as you know, consanguinity increase the likelihood of autosomal recessive disorder. The unique genetic profile where we found the BSCL2 mutation was the most common subtype, which is mainly due to founder effect in 42% of the cases. And the awareness and diagnosis were there many challenges because it is underdiagnosed or misdiagnosed in this area. And also there were access to genetic testing in specialized care in this part of the world. So we found, which is unsurprising, like any other studies with this disease, we found liver involvement in 70% of the cases with hepatomegaly and hepatic steatosis and cirrhosis, 51% with acanthosis nigricans, 64% with acromegaloid feature, 37% with hypertrophic cardiomyopathy, 78% of the cases that with reproductive problem like infertility or dysmenorrhea or amenorrhea, 23% of the cases with renal involvement, and 19% with bone and joint involvement. The metabolic complication, we have hyperglycemia in 46% of the cases, and with hemoglobin A1C more than 5.7%. 61% of the patient has a triglyceride more than 1.69, and also mild elevation in the liver enzyme. The medication usage mainly supportive, and this therapy does not address the underlying cause of congenital generalized lipodystrophy. So 21% of the cases with anti-diabetic medication, and 23% of the cases with lipid-lowering medication, and cardiovascular medication in 16% of the cases. The challenges in diagnosis and management, there is, as we see that the median age was 5.1 years, which is by itself, it is delay in diagnosis. However, we have 19% of the cases diagnosed after age of 12 years with severe complication. There is lack of awareness. Many healthcare providers are unfamiliar with lipodystrophy syndrome. There is overlap with other disorders like diabetes, obesity may mask the underlying condition, and there is limited access to genetic testing, and there is a need for family screening in this area because of high consanguinity rate, which make the family screening so important. What is the implication for early intervention? Because of high consanguinity, this is highlight the importance of genetic screening at risk family as early as possible. And important, once you diagnose one case, screens the first degree relative or second degree with or third degree with this mutation. And it is unsurprising that patient diagnosed less than 1 year has a fewer complications than the patient diagnosed after 12 years. The median hemoglobin A1C in older patient was 12%. Regular assessment of hemoglobin A1C, triglyceride, and liver function are essential to manage progression. And there is no one patient in this study received leptin replacement therapy, which is the only approved treatment for congenital generalized lipodystrophy-related metabolic issue. Limitation of this study include that it is a retrospective study, therefore it is prone to information and selection biases. Only 8 countries included, not all countries in the MENA region, so we need more larger cohort and more countries in order to generalize the validity of this study. So currently metriliptin is the, as a Professor Baris mentioned, it's the only approved medication for generalized lipodystrophy in United States, while in Europe and United Kingdom, it is approved in generalized lipodystrophy in patient aged 2 years and above, and partial lipodystrophy in patient aged 12 years and above. In Japan, for generalized and partial lipodystrophy, in generalized lipodystrophy, metriliptin with diet is a first-line treatment for metabolic and endocrine abnormality and may be considered for prevention of these comorbidity in children. And metriliptin may be considered for hypoleptinemic, which is leptin less than 4 nanogram per ml patient with partial lipodystrophy and severe metabolic derangement, hemoglobin A1C more than 8, and triglyceride more than 500. In our center, when we started patient on metriliptin, we have baseline investigation and monitoring parameter protocols. So we got demographic data. We have patient medical history, including consanguinity, first concern, age at diagnosis, current age, and time since diagnosis. Also in the history, we illustrate the history of hyperphagia. In examination, we check the height, weight, and body mass index, facial feature, including acromegaloid appearance, triangular face, large ear, mandibular changes, musculoskeletal features like lytic cystic lesion in the appendicular bone, large hand and large feet, soft tissue feature like generalized muscular appearance from birth, complete absence of metabolically active adipose tissue, and return some mechanical adipose tissue in joint, orbit, palm, hernia, and acanthosis nigricans. And also we check for presence of splenomegaly. In our cohort, we found splenomegaly in around 33% of the cases, and also clitoralomegaly and labial hypertrophy. From the lab point of view, we do hemoglobin A1C as baseline and also monitoring fasting plasma glucose, complete blood count, serum concentration of electrolyte, AST, ALT, urea creatinine, insulin, C-peptide, triglyceride and cholesterol, and also leptin level. ECG, echocardiography, abdominal and renal ultrasound, skeletal survey, bone age, and assessment of cognitive ability with age-appropriate scale. Current experience, we have 10 patients in our center, but I analyzed data of 7 patients started on metriliptin. 5 AGBA T2 or congenital generalized lipodystrophy type 1, and 2 BSCL2 gene defect. Found a mutation for BSCL2 is this duplication mutation. The age range between 5 to 29 years. The duration of a treatment between 1 to 3 years. They have shown statistically significant improvement in metabolic marker like hemoglobin A1C and the triglyceride level. Specifically, metroliptin has been demonstrated to reduce triglyceride and improve glycemic control. In addition, it showed improvement in the liver enzyme and also quality of life. We have also coming a study about real-world data on metroliptin in MENA region, and this is still not yet published. We have we collected so far 39 patients from many centers in the MENA region. We aiming to expand the understanding of clinical and metabolic outcome before and after metroliptin treatment, and address the unmet need for real-world evidence on metroliptin efficacy in the MENA region. And I will end with this app, which we call it IAM app. And this application, it is invented by me, and it is free of charge. You can download it from Google Play or Apple Store. It contains all inborn error of metabolism and medical genetic medication, their dosage, side effect, protocol for treatment. And in this app, you could find the metroliptin and its doses and indication and so on. With that, I will end my presentation. Thank you so much for your attendance and listening.
Thank you so much, Professor Al-Fadl. I will go now to see the questions, if we have questions. So while waiting for the questions, I have one question. I just found or diagnosed a patient, a 7-month-old girl, came to the clinic because of hepatomegaly, high liver enzymes, not yet having any features of lipodystrophy when she came. She was about 3 months, but high liver enzymes and high alpha-fetoprotein, hepatomegaly, abdominal distension. We thought initially could be a storage disease, could be other diseases. Then found to have a lipodystrophy, generalized lipodystrophy, pathogenic mutation, not yet having any feature of lipodystrophy. Her lipid profile still, her lipid profile is up and down, but most of the time in the normal range. And I don't know why it's up and down. She's in the same formula, the same diet, and the same regimen until now. Her liver enzymes drop down, double the normal, not so high. Hemoglobin A1C is still within normal. So when do we need, and I know you said like starting the medication as early as possible would be much better. Do you think this is the age at 7 months before any feature?
Yeah, if you are asking me, Professor Alhamdi, so I think that's a very good example, actually showing what we found in our registry as well. Not at this early age, because 7 months is really very early. So in many of our cases, we didn't have chance to monitor their liver disease as early as your case. But I think this is still very well aligned with what we observed. I personally believe liver disease is one of the things that develop earliest in congenital generalized lipodystrophy. Diabetes usually comes later, and then triglycerides, as you said, there can be up and downs, especially during the first 2 years of life. Sometimes these patients, they develop high triglycerides, and then they normalize by themselves. So, and then they recur normally around age of 4, 5, 6. So, but there are always differences from case to case. So some people believe there is a role of mini puberty there. Some people believe breastfeeding or formulas, that sort of thing. Sometimes they are lipid rich. These things can contribute. So there are a lot of unknowns here. Turkish Pediatric Endocrine Society is actually working on a similar project. They are trying to look at their cases from this perspective and trying to find their metabolic status, find out about metabolic status during very, very early ages, and whether this U-shape thing can be demonstrated there. This is what they're trying to. And the French group actually presented a very similar data set just a few weeks ago during the European lipodystrophy meeting. So their experience is actually very similar to what I just told you. I believe that's true. These patients develop early hepatic disease, and data from the NIH suggests that treating these patients as early as possible can be beneficial for their long-term metabolic disease profile and organ disease profile. But I think there is still limited data in that manner. That's why, as Dr. Majid Al-Fadel presented, in these sort of experiences from different parts of the world, and especially I believe Middle Eastern countries are very rich in these cases. So I think these experiences are very, very important for the rest of the world. So that's why sharing these experiences with the rest of the people in the field will really help them to educate them by themselves. But back to your question, still based on the NIH experience, I would suggest early treatment. The US approval doesn't mention as age limitation. In Europe, there is an age limit of 2. That's why in European countries they have to wait. But in the US, you can treat these patients, and if your country's regulations are following US regulations, then that can be something that needs to be considered.
And you mean this phenomenon of having like for an early onset of liver problem and then everything subsided and normalized, is this the usually seen in those patients?
This observation actually comes mostly from triglyceride levels and also diabetes. I don't believe anybody has a good data set to show whether this phenomenon is true for the liver disease, because at least we don't have that data set yet. And then the French group presented data based on diabetes and triglycerides as well. I believe there is very limited data when it comes to liver disease, but normally these things usually follow each other. That's why monitoring is very important. But if you have significant liver disease and then if you have leptin available, so then for the patient's benefit, it will be probably important to consider treatment.
Yeah, like as I mentioned, initially everything was high, and then at the age of 7 months subsided, normalized. So initial blood samples were lipemic. We cannot analyze it. It was very high lipid profile, high liver enzymes, high alpha fetoprotein, and then everything normalized. So thank you so much. We'll go to the second question here. Is mitroliptin the only medication or the only option to treat those patients?
If you look at the approved treatments for lipodystrophy specific medications, yes, that's the only lipodystrophy specific medication approved. But there are additional medications under investigation, let's say, so they are not approved yet. So mitroliptin is currently the only medication.
Thank you. Second question is mitroliptin can be used as a monotherapy or joined or with other treatment?
Professor Majid, would you like to answer this, because you have a large experience in our cohort?
It can be used with, with other medication as supportive management. Actually, most of these patients, when you see them, they are already on the supportive treatment. So adding mitroliptin will improve the natural history. However, we didn't try to use it as monotherapy alone.
Another question is, can be used to treat other diseases like diabetes, hypertension, hypertriglyceridemia, or not? Sorry, not hypertension, hypertriglyceridemia and diabetes.
No, this is definitely off-label use. As you know, leptin was tried for obesity even before 2000, and it failed. And then for example, if you look at the US PI, so there is a clear statement saying that the medication should not be used off-label for these kind of indications. So, but there are differences from region to region, from country to country. That's why everybody has to, I believe, follow their own regulations in that manner. But for common disorders like hypertension, diabetes, obesity, in the absence of lipodystrophy, my answer is no.
Thank you. Other question is, genetic testing is not always available. Is this the main reason for the delayed diagnosis?
If you allow me, Professor Akinci, to answer this.
Yeah.
It's one of the factors to delay the diagnosis. Maybe the clinical feature does not become more prominent until the child become older. However, the genetic testing will help in diagnosing this patient with more confidence.
Thank you. So it can be used for the children under 12 years?
Yes, we mentioned that
Yeah,
previously.
that's good.
Yeah.
And I don't know, this is young patient with fatty liver treatment. I don't know if we can, I mean, adjuvant treatment. I'm not sure about the question from Lubna. If you can join and ask your question, Lubna, Dr. Lubna. So young patient with fatty liver treatment, it's not clear for me actually, the question. By this, we ended all of the questions here. Thank you so much. It was great lectures and a very great night to listen to lipodystrophies, understanding comprehensive data from the MENA region. Yeah, thank you.
Okay, thank you, Professor Manak. Thank you, Professor Akinci.
And I would like to thank you again for the invitation. And I have to just say one thing. I believe the whole world is now learning from your experiences. That's very important.
Thank you. And thank you for the attendance, and please continue with following us at MIGMA with more and more webinar in coming year. Thank you so much.